Every single year, hundreds of thousands of patients suffer from severe bloodstream infections, and they usually start at a seemingly simple point of access. So let's dive right into this explainer. Today, we're going to treat routine device maintenance not as some basic chore, but as a totally critical life-saving intervention. Whether you're gearing up for your VABC exam or you're literally standing right there at the bedside, mastering the exact science of line maintenance is exactly what separates a standard practitioner from a true vascular access specialist. Think about it for a second. As the ultimate gatekeeper of your patient's bloodstream, your strict adherence to protocol is often the only thing preventing devastating infections, occlusions, and venous damage. A central line is basically a direct highway to the heart, right? And right there at the insertion site, there's this microscopic battle constantly raging. Millions of surface bacteria are actively looking for a way in. Your vigilance, your assessment skills, and your flawless sterile technique, those are the literal physical barriers keeping those dangerous pathogens off that highway. Consider this agenda our shift briefing. We are going to walk through the complete bedside workflow of routine line care. First, the daily visual assessment. Second, perfecting the dressing change. Third, hubs and disinfection caps. Fourth, precision flushing and locking. And finally, number 5, maintaining absolute sterility. Let's jump right into section 1, the daily visual assessment. So picture this. You walk into your patient's room. Before you even touch a single thing, your very first micro action is to look and palpate right through that intact dressing. You've got to constantly scan for specific signs of infiltration, extravasation, or infection, just to catch complications early. Look for erythema, redness, and feel for tenderness or induration. Is there any fluid leaking? Does the catheter actually look longer today than it did yesterday? Because if it does, that is a massive red flag for migration. You also need to zoom out a bit. Look at the patient as a whole. Systemic signs like a sudden fever, tachycardia, or hypotension, those could mean a localized issue at the site has dangerously escalated into full-blown sepsis. What we're looking at here brilliantly illustrates actual site complications. The profound erythema, the swelling, and even the severe blistering you're seeing are classic, undeniable signs of vesicant extravasation. This right here is exactly why your physical assessment dictates your next steps. If you see tissue necrosis or leaking like this, you stop that infusion immediately. No waiting around for a second opinion. Your eyes really are your best diagnostic tool, and reacting instantly can literally save the patient's limb. Now, here is a fantastic clinical pearl to memorize. Use this with your patients so they know exactly when to alert you that something's wrong. When you're teaching device care, use simple, highly visual language. Tell them, hey, your dressing should look like a clean window. If it gets foggy from moisture or if those edges start to peel back even a little, they need to let you know immediately. Empowering your patient like this makes them a vigilant, active participant in saving their own line. It's a real game changer. Moving on to section 2, perfecting the dressing change. So, the crucial takeaway here is that when that window gets foggy or lifts, executing a flawless, completely sterile dressing change is totally non-negotiable. Notice the strict difference in dwell times we're talking about. A transparent semi-permeable membrane or TSM dressing is the gold standard. Why? Because it lets you see the site directly and it releases moisture. That gets changed every 7 days. But say the patient is actively bleeding or has excessive moisture, then you might have to use gauze. Now, why is gauze only allowed for 48 hours? Well, it acts like a sponge. It creates this perfect, warm little incubator for bacteria to rapidly multiply. Because it completely obscures your view and traps that moisture, it has to be changed at least every 2 days. But keep the golden rule in mind. Regardless of the type, both must be changed immediately if they get wet, loose, or visibly soiled. Now, check out how the edges are lifting up right here. This is exactly what dressing failure looks like in the real world. By leaving it like this, you're actively exposing the insertion site to dangerous pathogens because that protective seal is totally broken. The very second a dressing stops being fully adherent to the skin, it completely ceases to be a sterile barrier. It must be replaced using an all-inclusive kit and a strictly sterile approach. When you're doing that sterile dressing change, sequence is absolutely everything. First up, you cleanse the site with alcoholic chlorhexidine gluconate. Specifically, we're talking greater than 0.5% CHG combined with 70% isopropyl alcohol, and you've got to use active friction. Now, step 2 here, absolute non-negotiable. You must allow that skin to dry completely. I can't stress this enough. If you fail to let the CHD dry all the way, you can cause a severe chemical skin burn, completely ruin the adherence of your new dressing, and totally negate the antimicrobial effect of the solution you just put on. Then finally, you apply your skin protectant and that new engineered securement device. All right, let's head into section 3, hubs and disinfection caps. Let's build on the actual mechanics of the line, specifically focusing on those needleless connector hubs. Honestly, this is a massive point of vulnerability. Every single time you access a needleless connector, you've got to perform a rigorous friction scrub. Now, 5 to 15 seconds of active friction scrubbing, yeah, that feels like an absolute eternity when you're super rushed at the bedside. But rushing this step literally pushes surface bacteria straight into your patient's bloodstream. Once you've scrubbed it, you let it dry for 5 seconds. Then you access it using ANT, aseptic non-touch technique, meaning you absolutely never touch the syringe tip or that newly disinfected hub. Incorporating passive disinfection caps is a fantastic, evidence-based strategy. It acts as a continuous safeguard for the hub right between access points. These caps actually contain a disinfecting agent, usually alcohol, that continually bathes those connector threads. So it's actively killing microbes, not just passively blocking them out. The evidence is super clear here. Using these passive caps significantly reduces intraluminal contamination and directly drives down the rates of central line-associated bloodstream infections. Which brings us to section 4, precision flushing and locking. Okay, so once you've safely accessed the hub, maintaining the patency of that line requires some exact flushing protocols. Definitely memorize these specific volumes for your exam. Peripheral IVs, they need 3 to 5 milliliters of preservative-free normal saline. But midlines and central venous access devices, CVADs, they require 10 to 20 milliliters. And hey, technique matters just as much as the volume. A steady push just creates this smooth river of fluid. What you want is a pulsatile flush, a push, pause motion. That creates a turbulent sort of washing machine effect that actively scrubs the internal walls of the catheter. Then you apply positive pressure right upon disconnection. That prevents blood reflux from backing up into the tip, which, by the way, is the #1 cause of fibrin buildup and clotting. When you are assessing CVAD patency, always use a 10 milliliter or larger syringe. You might be wondering why. Well, it simply comes down to physics. Smaller syringes actually generate a massive amount of PSI, pounds per square inch, right against the internal catheter walls. Pushing with a tiny 3 milliliter syringe could literally blow out the side of a PICC line. We use a 10 milliliter barrel specifically to minimize that pressure and prevent rupture. But quick caveat here. Once patency is verified, transferring a specific medication to a larger syringe just to deliver it, totally unnecessary. You can use smaller syringes for the actual medication administration, as long as you've already confirmed patency and you're pushing gently. If you meet resistance during a flush, you stop immediately. Do not push, period. You have to systematically check for mechanical issues. Are there closed clamps, kinked IV tubing, improper connections? Maybe the catheter is malpositioned. Forcing a flush against resistance is a complete non-negotiable hazard. Doing that can rupture the catheter entirely, or even worse, it could dislodge a clot directly into the patient's central circulation, causing a catastrophic pulmonary embolism. Just don't do it. Let's wrap things up with section 5, maintaining absolute sterility. Okay, let's step back a sec and look at the ultimate goal of all these targeted maintenance protocols we've talked about. Understanding the precise distinction between these two terms right here is one of the most highly tested and honestly highly missed concepts on your exam. CRBSI is the clinical definition you use when you are actively diagnosing and treating the patient. You are confirming that the catheter itself is the exact source of the infection. CLABSI, on the other hand, is a broader, laboratory-confirmed surveillance definition. That one is used for facility reporting and tracking. Knowing the difference really highlights just how meticulously we track these systemic failures. And how do we prevent those infections? By rigorously applying this infection prevention bundle. We're talking strict hand hygiene, adhering to maximal sterile barriers during insertion, proper hub scrubs, and maintaining pristine dressing integrity. But that final point on the list, it's often the most overlooked, the daily necessity review. You must actively review the necessity of that line every single day. The absolute best, 100% foolproof way to prevent a line infection, remove the line. If the patient doesn't strictly need it anymore, you have to advocate to get it pulled promptly to eliminate that risk entirely. Every single protocol we've covered in this explainer reinforces your ethical duty to the patient. It leaves you fully equipped to champion their safety right there at the bedside. When you truly master these maintenance steps, you stop reacting to complications and you start preventing them entirely. Remember, every time you skip a 15-second hub scrub or you try to rush a dressing change, you're rolling the dice with your patient's life. You are their final gatekeeper. So the next time you prep a flush or change a dressing, I want you to ask yourself, are you just checking off a chore, or are you acting as the frontline guardian of this patient's life?